So, you're probably wondering, how does the surgeon try to study their anatomy? Why do they actually know where things are located, and how do they expose it? How do they understand things which, when you look at, doesn't really make sense, and then voila, everything's like dissected, and they were able to identify things without injuring? Well, that's what we're actually going to talk about today. And we're going to use a inguinal hernia, the mypectineal orifice, as our teaching case. We're going to show an actual picture, and then we're going to help you understand how surgeons think in order to understand it, and then be able to not only memorize things, but to understand the concept of how to identify structures in the real world, and how do we actually dissect it. So let's get started. So when actually looking at anatomy and trying to explain it, especially to either medical students, residents, or even patients, you want to give an orientation. So talking about the mypectineal orifice, we're going to go through inside after developing the flap, which may include your peritoneum and part of your transversalis fascia. So in this instance, we're going to do the right groin. So we're labeling it right. Afterwards, you want to label superior, inferior, and we're going to do lateral and medial. As I mentioned in teaching how to operate, if you want to learn to check out the other videos to help a better understanding how to prepare yourself, this is going to be points of reference, and you're going to use reference structures. Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button, and let's keep on going. So what structures can we identify easily that don't move? They're non-mobile. So in the right groin, we're going to do a y-axis, and then we're going to do an x-axis. The x is slightly curved on the lateral. Okay, so what does this show? What structure would be vertical? That's going to be your inferior epigastric vessels. What's going to be my medial aspect? My medial, what can we see? That goes here. So we're going to draw Coopers, which you could see overlying the periosteum of your pubic bone. And then if you trace this to an imaginary line, it becomes your iliopubic tract. Okay, so these are two things, non-mobile, that we can identify. Now, where does the concept of explaining the anatomy come in? We only have two structures. Wait. Gotta give me a second there. This now divides it into 4 quadrants. You've got the outer upper, and this is going to be on the lateral. This is going to be the inferior lateral, and this is going to be your medial and your superior. So let's start with the outer upper. And so if we draw a circle here, and we'll pretend this is a male. So this is going to be, in the outer upper, our internal ring. What are the two things that go in our internal ring? Well, there's two things. One is going to be your spermatic cord, and the other one is your vas deferens, the one that looks like an angel hair spaghetti. And so now this forms a triangle. And if you look at this, these are two retroperitoneal structures. For guys, when we're born, remember, our testicles descend from the abdomen because it gets too hot, and then it goes out into the internal ring, to the external ring, and into the scrotum. What should happen is the inguinal canal should actually close over, not strangulate, but just close over naturally, and prevent things from getting in there to prevent an indirect hernia. So this is going to be indirect hernia. And so if that doesn't close, we call it a patent processus vaginalis. So this is retroperitoneal. When you have a hernia, it's technically a flap of parietal peritoneum that gets overstretched and goes in there as it bulges. So you're increasing your abdominal pressure, whether it's going to be fat or guts that starts herniating outward, it would stretch out this parietal peritoneum. And that parietal peritoneum, when we do the dissection, we have to dissect it and separate it from the gubernaculum testis and separate it from the spermatic cord and vas deferens. Once you've separated that parietal peritoneum, which is part of your flap, it's going to be coming down here. It's now called parietalized. Okay, well that forms a triangle. What is going to be under that triangle? This is going to be triangle of doom. Why is it called doom? Because your iliacs are there. They're going to be your external iliacs going into your femorals. So remember the term navel, nerve, then we have our artery, and then vein, empty space, and lymphatics. Where does lymphatics go? Well, lymphatics goes down here. Actually go back to the block. Down here. And this is going to be where your femorals are. Artery and vein. Boom, 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 boom. We shall draw it down there. That's your vein. And this is your artery. Okay, so they're going there. And again, you also have lymphatics. Nerve, artery, vein, empty space, lymphatics. And so that's the relationship of your femoral canal to your internal ring and indirect hernia. Okay, so when you draw a triangle here to the iliopubic tract, it forms another triangle there. And that's going to be the triangle of pain because your nerves are there. So when we're dissecting this area, you want to keep the fat down and avoid complete exposure of your psoas muscle because the extent of dissection includes exposing the psoas, but it has to be covered, but you don't want to expose the nerves because I prefer not to put the mesh on top of the nerves and cause some scarring around it and then end up with chronic pain. So there's our triangle of doom and triangle of pain. Afterwards, what else is there? Well, remember this triangle? They do love triangles in the inguinal hernia. So we have your Cooper's here, your inferior epigastric, and your lateral border of your rectus muscle. That's your rectus. And this forms Hesselbach's triangle. And this is going to be your direct defect. In here, what are the organs that's going to be here? This is going to be your bladder. And interior to it is going to be your space of Fretzius. Where's your obturator hernia? It's going to be way down here. And so when you look at a diagram like this and proceed to perform the surgery, you can understand the extent of your dissection, where structures are in relation to each other when you're dissecting them, where should I take care of, what should I avoid, and when should I be careful. And this shows you all the aspects of the mypectineal orifice when you're putting down your pre-shaped mesh to cover all the defects during a repair. And so really understanding stick figures when doing reference of structures where you can understand where things are based on relationship of structures that you can identify. So if you guys appreciated the anatomy lesson here, if you guys have any comments, please type it in the chat. click a like and subscribe, and check out our other videos, and I'll see you guys next time.